Dr. Jake Poshi.
So Dr. Philip Kuruvilla and sir and Dr. Ashish, just please stay on for our session also. So that was a wonderful first session we had on the basics of MICS. And for all those who have done at least 50 or 100 and now you're confident you're able to do the whole surgery by yourself without any assistance, then now you're talking about how to make the surgery look more cosmetically pleasing, how to get perfect vision post-operatively, how to reduce the astigmatism, and these are the things. And then complications, you have to try to start dealing with it yourself in an efficient way so that the patient has good vision post-operatively. So I'll be going first, and I am a surgeon from Trivandrum. I work at Aradhana Eye Hospital. So here, what we're going to try to do, the first session, we'll talk about the CCC and the tunnel and how you can refine your technique. So in the first session, we heard very clearly that for novice surgeons, it's very useful to make a larger size rhexis and a larger size tunnel so that you won't end up in having all these problems, that the complications that we saw just now. But then once you're a little bit more experienced, you should try to now limit the size of the tunnel and the rhexis, because as we're going to discuss now, a lot of the things that post-operatively, the optical result that you get is based on these two things. So we all want a lens looking like this with the capsule nicely surrounding 360 degrees. This is not an MSICS, this is a phaco incision. This is a 4.75 sized rhexis, and you cannot, unless it is a Morgagnonian cataract or something, you cannot get this size of a capsule. So even more than phaco, in MSICS, your rhexis size has to be very, very well optimized. And so as you get more experience, you should learn how to try to make the optimal size. If it is too small, it's a problem. If it is too large, also there are certain problems, especially if you're going to put in foldable IOLs. So there is this thing where axial stability of the IOL, this is the anterior-posterior stability. So we know that there can be tilt and astigmatism and all if it pops out from the side. But there is also the thing where the lens sits a little bit more anteriorly if the rhexis size is large. So if you make a 6.5 millimeter rhexis, your lens will be sitting much more anteriorly in the bag as compared to, say, a 5 millimeter rhexis where your lens will be more posteriorly positioned. So this thing about effective lens position that we use in our calculations in Barrett and all these, that actually depends a little bit upon this thing. So if in one rhexis you're doing a 5, the next one you're doing 6.5, then your effective lens position will vary. And this is one of the reasons you have kind of inconsistent results when you do a MSICS surgery. So very important to do consistent size rhexis in most of your cases. Then obviously this is logical. If one end of the intraocular lens is not covered with the capsule, it will pop out anteriorly. And that edge will look a little funny, and anterior capsule will fuse with the posterior capsule, posterior epithelial cells will migrate, and then you have an early PCO in that area, and the patient is not so happy. The other thing that we should remember is that the pupil sometimes is not well dilated, or it may be dilated a little bit. This is a very obvious sort of a thing I'm showing here, but even a little bit so, in SICS more than phaco, you tend to make a slightly larger rhexis, right? So when you make a larger rhexis, even if it is a little bit eccentric, you will end up having the IOL sitting like this. So it is important for us to see that the rhexis that you're making is exactly central. So when we have the pupil size exactly in the center, you can see how decentered this little rhexis is. And this may be a 4.4 millimeter rhexis. Even so, you can see the intraocular lens is tilting out, and that edge of the optic is very much out of the bag. So these things seem like irrelevant things when you're putting in a rigid lens and you're making a huge 8 millimeter size incision. But believe me, there are so many cases, camp cases that we do. You put in these rigid lenses that cost barely anything. They all have 6.6 post-operatively. And then you ask them later when they come 2 years later, now we'll put in imported foldable. They said, no, put the same lens as you put last time. And that is just basically put it in the bag, get a perfectly sized rhexis in the center, and they do much better. So decentration causes tilt, and that tilt, if it is more than, say, 5 or 6 degrees in the AP direction, 5 or 6 degrees, will cause a visual obscuration and a little bit of astigmatism. And then the lens edge defects also come into play. We'll talk a little bit about that. Then there is eccentric optic capture that happens in the area where the anterior and posterior capsule fuse when it is beyond the IOL optic. And then, of course, early PCO formation also happens in these patients. So many things by just a small thing about decentration of the rexus. So, and when MSICS, you're making a larger size CCC, and therefore you have to be even more careful about the centration of your capsular rexus as you do it. The other thing is this spherical aberrations. Now, all the latest foldable lenses and all are all aspheric, but many of these cases in hard cataract, you may be putting a rigid IOL, and these rigid lenses are mostly not aspheric lenses. So in these, you have this kind of a distortion or a spherical aberration sort of thing, and in the corner or towards the edge of the lenses. Whereas aspheric lenses, you can see because of the shape, it is not perfectly spherical, it flattens out towards the periphery. So as we all know, the spherical aberrations, it negates that and causes a good focus point. And so the image is relatively more clear in aspheric lenses. But in aspheric, if your lens is not an aspheric lens, towards the periphery, it will be like this. So if it is placed center in the thing, it doesn't really affect it because through the center of the pupil, you'll be able to see very clearly. But if the lens is sitting like this and with a sort of a decentered CCC, you will have a lot of obscurations and you'll be wondering, with the pupil constricted, it doesn't look too bad. Why is the patient complaining? He's seeing 6/9 vision. But the point is, we are not exactly evaluating the spherical aberrations and all the other edge effects that the patient has. So this is what I was talking about, edge defects. So when you have a decentered IOL especially, suppose this is a cross-section of the IOL here and this is the edge of it. When there is any sort of bright light hitting the L, we all know that there is an in-focus image that comes through the side of the thing, but there is also a reflected image that comes up through the edge of the IOL. And in order to prevent this positive photopsias, there's so much technology that goes into all the latest IOLs to make the edge of the intraocular lens, to make the reflected image a little less prominent. But if that thing is lying somewhere near the center of the pupil or anywhere within the pupillary margin, you'll definitely have much more edge-related defects. So the other thing, to make sure you try to do a CCC in every case, you might think it is an NS5, it is an intermittent cataract, we'll just do some can opener and get away with it. Anyway, the patient has CFCF or whatever. Definitely it is worth to do a capsular rexus, even in those cases. Do a mini rexus, decompress the bag, and make sure you end up with a CCC, because any procedure that you need to do post-operatively, which may be even 2 or 3 days later, then you still need to have, 2 or 3 years later, you may still need to do it. For example, these hydrophilic lenses, some of them are infamous for tilting like this and bending inside the bag. And if you need to explant this and put in another lens, it is so much more easier if you had a CCC in the first place. So smaller rexus, 2 smaller rexus, we all know. In MSICS, you'll end up with a nucleus drop, PC rent blowout and a nucleus drop. If it is, and then you might, as we showed in the previous one, you can end up with a zonular dialysis and all these things. And if it is 2 larger rexus also, what we discussed, PCO formation is earlier and tilt and all these things can happen. So optimal size rexus is very important. It's not the easiest thing to get the optimal size because the depth of the so the thickness of the lens is something a little difficult unless you have some optical biometry or something. It is a little difficult to assess how thick that nucleus is. And so sometimes you make a 5.75 and then you find that it is not enough. So when it comes to hard nuclei, I would suggest you stick to 6 millimeter, but remember that you have to keep it exactly central rather than anything else. The scleral tunnel, of course, we all know, NS1, try to make it a little bit more judicious and have a little smaller 5.5 external lip. Internal lip will stay the same size no matter what size of nucleus you're doing. And then as the nucleus size becomes bigger, you have to make a slightly larger frown-shaped incision. So get your tunnel right, never stretch the wound as I explained in the previous one. Internal lip, the valve, it has to be a valve effect, so make a U-shape rather than a straight or frown shape. Try to shift to temporal incision, and Dr. Leena will be talking more about the temporal incision. And when in doubt, always suture. In these NS4s and 5s, when you make a humongous external lip, that will definitely cause astigmatism, whether you're doing superiorly or temporally. And so there is no harm to put a suture. It will reduce the astigmatism and also prevent postoperative leak and hypotony, hyphema, and eventually it will prevent infection. The depth we already talked about the depth and all the basics, so I will not go into those things. So, thank you. So, Dr. Alex was supposed to take the next one. Sir is not here. So, We'll go on, I'll do that one also now, and then we'll have a small discussion, then we'll go to the next topic. So the next one is how to have clear corneas consistently. And if you make a large rexus and a very large tunnel, you're almost consistently you can do that. You just use a lot of visco, and that is all you need. You don't need a 10-minute presentation. But that happens with experience, and so you can say it's just if you do more than 1,000, 10,000 surgeries, you'll have consistent. But then we are trying to look at how we can do this with the limited experience that we have, how we can produce the best results, because at the end of the day, the patient will decide for himself, no matter what anybody else says. Patient himself will decide, is this a good surgeon or not, depending on how the results are the very next day. So when you're doing this, you must consider to have a clear cornea the very next day. And how you do this is these small tips that everybody can do. And this one thing which already Sir had mentioned, the blades that you use should not be blunt. So many of us, when you're doing our PG, the blades may be autoclaved and all this, and you may be not using extremely very sharp blades. But it doesn't cost much, and it really, really makes a difference in your incision and how confident you can be and how much pressure to put as you're doing the tunnel and all these steps. So use sharp blades, and as Sir said, if the same company is used, well and good, because slight difference in angulation and all will be there. But using blunt blades can cause all these problems, and cosmetically the patient will not be very happy the next day. So, manipulation and all can cause corneal edema there itself, and there's more chance of Descemet's detachment of if you're using a blunt keratome as you enter the eye. Then you're gripping with your left hand. As Sir said, you have to have a good grip. That grip itself, if it is a blunt forceps, you'll be ripping the conjunctiva as you're making the incision. Then inconsistency and bluntness, you might end up, it might be sharp even after the second time autoclaving, or it may be extremely blunt. So you will be putting more force thinking it is blunt, and then you might end up having a premature entry. So better to use disposables. In this particular step, let us not try to save too much money. Try to get fresh blades and for this step. The second thing is entry. This is a very small thing to consider, but entry into the eye. These instruments, as you go, you're so focused on doing that particular step. CCC, you're so focused on, starting the thing, making a flap. But you don't realize that it starts actually even before that. As you introduce that into the eye, make sure the sharp end of that instrument, whatever instrument you're using, is not piercing through, is not cutting through the posterior lip of that side port, or it is not causing a Descemet's detachment. So every time you enter the eye, you should make sure that you're going with the sharp end a little bit sideways, so it is not injuring anything. Then whether you're using a dialer or anything you introduce in the eye, have a particular way. I usually tilt it to the right a little bit and enter the eye. You can do your own thing, but be conscious that these things also make a difference, because if you have a large Descemet's detachment in that area post-operatively, it just spoils however beautiful the rest of your surgery is, it spoils the whole outcome. Then whether you're putting in an AC maintainer or intraocular lens, all these steps you have to be careful that you're not scraping through the endothelium, you're not touching the endothelium, because that can easily cause a Descemet's detachment, especially in those who are prone diabetics and older patients and all. So in phaco, we are taught, the central safe area and all that. You can use the same central safe area in MSICS also. Make sure you don't touch the iris. The iris causes quite a lot of inflammation. So this pigment release is one thing that is terrible in MICS if you have to deal with with the iris. So ideally in these cases, try not to touch the iris at all during your whole procedure. Of course, if the nucleus is very, very large, then you will end up touching it here and there. But you should be conscious about the fact that the iris is a no-no. Just like the endothelium and the PC is a no-no. You're not supposed to touch it at all. And your results you will see post-operatively is much better. So, and the most important thing to, get clarity on the clear corneas the next day is obviously nucleus delivery. So the larger the nucleus, the more difficult this particular step gets. And of course, with the smaller eyes and all that, the more difficult. You can complicate the matter on top of this if you make a very small tunnel also. So in this particular thing, if you have a small eye, if you have a hard nucleus, don't try to be too cute and make a very small scleral tunnel. Here you have to be very, very liberal with your incision, and you have to protect the endothelium with some way or the other. So either you put in viscoelastic into the eye, even before doing hydro dissection, you can, just like you coat the endothelium with viscoat, just like that you can put a little bit of 2% HPMC into the antechamber, the viscoelastic which we all commonly use. And then you can go in with your hydro procedure so that when it pops out, it doesn't directly touch the endothelium. And then you have to use something. Here I've kind of attached a 26 gauge needle to a visco syringe and injected, so the eye stays well, well formed even after the nucleus gets delivered. Or you can use any of those techniques which they talked about in the previous session. You can use irrigating vectors and phaco sandwich technique and all that. The other thing is when you're using anything toxic in any of these intracameral agents, you have to try to protect the endothelium. So make sure you do all these under a bubble. That is judicious and very probably a good idea, because you want to prevent any corneal edema the next day and iris pigments release, etc., which some of these cause. The other thing is cleaning out the viscoelastic, because you've done a beautiful surgery, the intraocular lens is perfectly aligned in the center, and you think, wow, this patient is going to have 6/6. And the next day, the patient may have hand movements, and his pressure may be 50. And this is because of the retained viscoelastic. So it can be there in the angles, it can be there in the bag, it can be there in the sulcus, behind the IOL. So actually, this particular step, the more senior you get as a surgeon, you'll realize this washing out this thing takes more time than all the rest of the procedures together. Because you want to, if you've used a lot of viscoelastic, you have to make sure that full angles and all are clear, especially if it is a glaucoma patient. You have to be very sure that all this is cleared out. And you have to make sure meticulously to go behind the intraocular lens also. That is a risky procedure, but the earlier you start learning how to do that, the better your outcomes will be. So I'll just quickly just take you through this lens. Everything that we have discussed, we will just quickly run through. So use sharp blades to prevent Descemet's detachment from happening. Then anything you're using inside the eye, do it under the cover of an air bubble so that you'll have a better outcome. And then be judicious with the size of the CCC that you're doing. Make an adequately sized incision. It's a good idea to do it under, make a conjunctival flap. Don't try to do this transconjunctival thing unless you're confident. And any incision you make, use new blades so that you'll have a neat cut rather than any cut that can cause a Descemet's detachment. And hydrodissection, and before that use viscoelastic in the anterior chamber of the eye. Try not to touch the iris during the whole procedure. And you can do that. No matter how big the nucleus is, you can actually get away without touching the iris. And if you made an adequately sized thing, the iris will not come out through the incision that you've made. So you just have to make a properly adequately sized incision. And make sure you wash all the viscoelastic behind the eye also, behind the intraocular lens also. And any intracameral that you're using, don't just flush it into the anterior chamber. Try to go into the bag and do it so that it doesn't really affect the endothelium much. So slightly harder case also, you can come up with a clear corneas the very next day. And it is just exactly the same steps. Just be judicious, because here you have a little less space. And unlike what they taught us in the first session, not always do you have to do this under the pupil sort of thing, especially when you have too many things to worry about. It is always good to visualize what you're doing, even in SICS. Now, it is a pain to put these hooks in and to take them out and all that. But at the end of the day, you want a clear cornea. You want the IOL sitting in the bag properly. And for that, you need to visualize. So here, though this takes an extra 5 minutes to do, try to put in some kind of a pupil expansion device. And then when you're doing an SICS, this actually gets in the way of your tunnel. You can see here that these two incisions, these two iris hooks are actually through the tunnel area. So obviously, before you take out the nucleus, you have to remove these two hooks. So here, after the CCC, under direct visualization, you're doing the CCC. Here, this is an NS5 cataract. So here, I'm doing a large 6mm size rhexis. You can hardly see the edges there, except in that area and here. But you're doing it under direct visualization, so it is not dangerous. But if you're doing it under that small pupil, you really don't have any idea, and it is partly luck when you're doing it. So here I've removed those two incisions, because now it is going to be difficult to take it out otherwise. And then you pop it out in any way you like, whichever you're comfortable with. Bring it into the AC. And now here, if I don't remove those two hooks, I may rip the iris in that area, the sphincters in that area. So that also. So in SICS, it is a bit cumbersome. In phaco, from starting to end, you can do it with the hooks in place or with whatever expansion device in place. Not so in SICS, it takes a little bit longer. So these are the things that we have talked. Thank you.